our audience and the delegates and the faculty, please stay with us, because there will be live poll at the end of the presentations, so then we can select this evening with a very short interval the winners. So thank you very much. If we could move to the next presentation, which I think is recorded and comes from Dr. Yumi Shiina. And Yumi spent with us 2 years. She comes from Tokyo, Japan, and both from St. Luke's International Hospital, our dear colleague, Professor Niva, and also from Tokyo Women's Medical University Hospital, Dr. Inai. Yumi's presentation and theme is secondary sarcopenia assessed by computed tomography can predict hospitalization for failing Fontan circulation. If we could show her recorded presentation now, please.
Hello, I'm Yumi Shiina, St. Luke's International Hospital, Tokyo, Japan, and the Tokyo Women's Medical University Hospital. I'm very honored to have such a kind of opportunity today, and I appreciate so much Professor Gazuris, delegate, and ex-colleagues and friends at the Royal Brompton Hospital. I'm very sorry for this pre-recorded presentation due to the time difference between London and Tokyo. Today's topic is secondary sarcopenia assessed by computed tomography can predict hospitalization of heart failure, failing Fontan situation in adults with Fontan circulation. Sarcopenia, the definition is loss of skeletal muscle and strength. This is Asian Working Group criteria. I will introduce our prior study. A total of 170 adults with CHD in outpatient clinic. We performed the interview using a food frequency questionnaire by the Japanese Ministry of Health, Labor, and Welfare. We also measured the skeletal muscle mass by BIA. Dietary intake ACHD and expectancy was better compared to age-matched healthy controls in national survey. However, 14% in males, 18% in females of adults with congenital showed sarcopenia. This is also a prior study. 15 CHD patients performed resistance training, home exercise, and amino acid intake for 2 months. A short-term outcome was excellent. Skeletal muscle mass increased, body fat decreased, NT-proBNP improved, and edema index improved as well. But long-term effects are unknown. The conventional method to measure the skeletal muscle mass are dual energy X-ray absorptiometry, which needs special equipment, and bioelectrical impedance analysis. This is not available in patients after pacemaker implantation. In this study, we use a CT scan to measure the surface major muscle. This is the 3D CT reconstructed images. Left-hand side is a 30-year-old female Fontan patient. Right-hand side is age-matched controls. Quantity and quality of the PMM are totally different between the two. PMM are important core muscles that are known to deteriorate at early stage of sarcopenia. And the PMM and the tendons are isolated from other muscles and easily and accurately detectable by using old tracing software. The aim of this study were to quantify the volume of surface major muscle and to investigate whether the volume of the PMM is relevant to heart failure hospitalization, failing Fontan situation in adults with Fontan circulation. The single-center retrospective study consecutive enrollment of 150 54 adults with spontaneous circulation who underwent abdominal CT scan. CT scan for the following indications: acute abdominal pelvic pains, inflammation of the lower extremities, ascites and liver dysfunction, to rule out deep vein thrombosis, to assess the femoral veins before catheterization and ablation. The definition of heart failure in this study was hospitalization due to decompensated heart failure, including volume overload, ascites, edema, and oliguria. We excluded hospitalization for ablation, cardioversion, hemoptysis, treatment of liver cancer, and only infection. Cath data in only 38 patients were available, which were within 2 years of CT scan. 38 and 6-month adults were also enrolled who had rushed to the emergency room. CT scan due to acute abdominal pelvic pain, inflammation of the lower extremities, suspected DVT, and no serious diseases were found. We examined their medical records, and the patient with chronic diseases were excluded. Non-contrast healthcare CT scanning from below the diaphragm to the bottom of the pelvis was performed. We used a 320 slice CT scanner with a reconstructed image with the slice thickness of 5 mm with no gap. PMMs are detected by using auto-tracing software. In order to confirm the accuracy of the auto-tracing measurements of the CT image, we measured the core skeletal muscle of 16 patients using the BAI method and evaluated. This is patient characteristics. Average age 32 and NYH functional class 1, 18 patient, class 2, 89 patient, class 3, 41 patient, class 4, 6 patient. 124 patients after TCPC and 30 patients after atrial pulmonary connection. In Fontan patient, BSA, saturation, and PMM were lower than controls. This slide shows the correlation of the PMM in Fontan males and females. NYHA showed a good correlation in males. In females, the age, NYHA, and the creatinine showed a good correlation. Prediction of heart failure hospitalization in Fontan males. On the univariate analysis, NYHA, BNP, PMM, albumin, creatinine, liver cirrhosis, and PLE were good prediction. On the multivariate analysis, NYHA was the best, and creatinine collected by PMS was also the prediction. In Fontan females, age, NYHA, BNP, PMM, albumin, saturation, and liver cirrhosis, and the PLE were a prediction on the univariate analysis. On the multivariate analysis, NYHA, BNP, PMM, PLE were the best predictions. Creatinine collected by PMM was also a good prediction. This slide shows the Cath data in PMM in only 38 patients. CBP at rest and the pulmonary vascular resistance showed a good correlation, negative correlation. And the cardiac index also showed a similar tendency, but not statistically significant. Ejection fraction in the ADP, no correlation. On the univariate analysis, pulmonary vascular resistance was the good prediction. In both males and females, the lower PMM group showed the poorer freedom from heart failure hospitalization. Association with mortality, only 6 patients died and 3 patients due to heart failure. The number was too small and to be analyzed. The validation of the CT scan. This slide shows the correlation of the PMM by CT and the core skeletal muscle mass by BIA method. Two methods show the good correlation. Discussion. The possible reasons for secondary sarcopenia in Fontan patients mainly venous congestion and low cardiac output. Additional factors are inappropriate nutritious intake and unhealthy non-active lifestyle, absence of regular exercise since childhood, poor absorption due to gastrointestinal edema, hypercatabolism, hormonal imbalance, inflammatory process, oxidative stress, and cellular proteolysis. We can say sarcopenia is one of the major late complications in Fontan circulation. As you know, the skeletal muscle pump and the ventilator pump are very important in Fontan circulation. In particular, skeletal muscle pump is an important determinant of cardiac load during exercise. So, skeletal muscle is an essential organ for Fontan circulation. Growth hormone release and other hormones play protective roles for heart failure. Females tend to have faster onset of muscle loss due to muscle turnover. Sarcopenia and liver kidney dysfunction in Fontan. Pathogenesis of sarcopenia, pathophysiology of sarcopenia in Fontan is complex and multifactorial, not fully understood. As for liver dysfunction, in this study, most enrolled patients with mild LC and mild malnutrition. So the liver dysfunction did not directly relate to PMM. As for kidney dysfunction, which is often underestimated, creatinine level corrected by PMM was an important prediction. Secondary sarcopenia may be a comprehensive marker of the multi-organ diseases. Limitations. A retrospective study assessed only the PMM, not the whole body muscles. This study was performed in a tertiary care center for adults with CHD. Therefore, the severe Fontan cases are referred. The frequency of heart failure hospitalization in Fontan patients was unexpectedly high. A possibility of a selection bias in controls. The main reason why we selected these controls was to avoid unnecessary radiation exposure toward healthy controls. Exercise capacity and PMN Fontan sarcopenia study is now undergoing. In conclusion, a low volume of the PMM is an additive prediction, additional prediction on hospitalization due to heart failure, failing Fontan situation in adults with Fontan circulation, particularly in Fontan females. Secondary sarcopenia may have a negative impact on the prognosis of heart failure in this population. The assessment of the skeletal muscle mass was also maybe one of the comprehensive screening tools for multi-organ dysfunction in Fontan circulation. Thank you for your attention.
Thank you, Dr. Shiina, Yumi, and excellent work and novel data. Very well presented. Obviously, you can't have or take questions. I just wonder whether Gruson Veltman, for example, is in the audience. He alluded to some of this in his second presentation. In the meantime, there was a question from our delegates regarding the first paper as to whether any fenestrated devices were used in that cohort, and I checked with Dr. Hesse, confirmed that there were no fenestrated occluders in any of them. So maybe Gruson is having a bit of a rest or dealing with patients. We have him back tomorrow. As I said, we kept him busy. I think we should move to the third.